Hello Damsonians, welcome to this topic of asthma. Asthma is an extremely important disease, we know, because of its high prevalence, high incidence all over the world. It's an important non-communicable disease. But moreover, along with the entire topic of asthma, we are also going to understand the important GINA 2021 updates, the 2021 updates and the relation to COVID-19. So please look forward to this topic, these additions in this video lecture. So we have always studied asthma in detail because not only is it a very practically relevant topic, but it is extremely important for theory exam too. So let's get started with asthma. Every disease we start with the definition that what is asthma we want to know. So asthma is defined as the hyper responsiveness of the airway. It is defined as the hyper responsiveness of the airways. It is defined as the hyper responsiveness of the airways due to what? Due to a multitude of stimulus, to a multitude of stimuli. So the hyper responsiveness can be triggered by a multitude of stimulus, both exogenous and endogenous. Both exogenous and endogenous, it is going to be there. So there is a hyper responsiveness of the airway to a multitude of stimuli, both outside the body and inside the body, characterized by attacks of, episodes of bronchospasm, episodes of bronchospasm with excellent bronchoreversibility, with the excellent bronchoreversibility, very important. So this is the entire definition of bronchial asthma. So what is bronchial asthma? Bronchial asthma keywords को देखो, hyper responsiveness of the airway. Which part of the airway is involved? Entire length of the airway is affected. Remember that in asthma, entire length of the airway, there is a hyper responsiveness of the airway to a multitude of stimulus, which is characterized by episodes of bronchospasm, and the key word here is with excellent bronchoreversibility. The key word is with excellent bronchoreversibility. We studied when we spoke about spirometry, when the improvement in the FEV1 is more than 12% after salbutamol inhalation, it is called as excellent bronchoreversibility. That is the characteristic hallmark of the disease. So what is the epidemiology of the disease? Fine, it is hyperresponsiveness, but when does it occur? 80% of the cases occur before 10 years of age with male preponderance. 80% of the disease occur before 10 years of age with a male preponderance. 20% can occur after 30 years. After 30 years, equal distribution in both gender. So 80% occur before 10 years of age. So these are called as the childhood onset asthma. These are called as childhood onset asthma, which are called classical. Classical matlab more common, that's all, याद रखना है. Classical means more common. Classical means more common. They can be, or the patient can be having adult onset asthma. The patient can have adult onset asthma. 20% of the cases are adult onset asthma occurring after 30 years of age. Equal distribution in both genders. Equal distribution in both genders. What is the cause of the asthma? What is the cause of the asthma remains unknown. We don't know. Why the asthma occurs, we don't know. But we do know the pathology is inflammation of the airways. The pathology we know, there is the inflammation of the airways. That is correct. So asthma is a disease most commonly affecting young boys. We don't know why it occurs, but we know that there is inflammation of the airway. So based on the pathology, see, inflammation is common, but why the inflammation occurs? Based on the mechanism of inflammation, they are divided into two groups. They are divided into two groups. What are the two groups? The two groups are the extrinsic asthma. Extrinsic is also called allergic asthma, also called classical asthma because it is more common, also called atopic asthma, also called as atopic asthma. It is going to be called as, I think the name is self-explanatory at a lot of levels. So more commonly, inflammation of the airway is due to extrinsic, allergic, classical or atopic asthma. But what is the other possibility? Intrinsic, which is also called as idiosyncratic. Idiosyncratic, because why the inflammation occurs is also poorly understood. Intrinsic or idiosyncratic, also called as atypical asthma, called as the atypical asthma. It is important for us to differentiate between the two. It is important for us to differentiate between the two. Okay? So, inflammation of the airway, which makes the airway prone to bronchospasm, is the problem in asthma affecting young boys. But why the inflammation occurs can be divided into two. More commonly, it is going to be classical, related to allergy due to external factor, extrinsic, while the few can be due to intrinsic factor, maybe genetic, but we don't know exactly why it occurs. Hence also called idiosyncratic asthma, also called as idiosyncratic asthma. So why is it important to differentiate between the two? Why is it important to differentiate between the two, the extrinsic and the intrinsic asthma? And how to differentiate, that is also equally important. So 2 questions we have to answer: how to differentiate and why to differentiate. Let us start with how to differentiate. If you look at the extrinsic asthma, they are likely to be more commonly childhood onset. They are more commonly the childhood onset asthma. They are more commonly the childhood onset asthma. Majority cases are associated with, also have other allergic problems like allergic rhinitis or episodes of urticaria. Episodes of urticaria can also be present. So if it is extrinsic, when will you suspect? More likely in a childhood onset, where the child also complains of other allergic problems like rhinitis and urticaria. How are the attacks? The attacks of bronchospasm asthma are relatively frequent. The attacks of asthma are relatively frequent, but each attack is mild in intensity. Each attack is mild in intensity. Fine. So what if it is frequent? The problem is not heavy. It is not heavy. Attacks are frequent, but each attack is mild in intensity and has got excellent response to treatment. It has got excellent response to treatment. It has got excellent response to treatment. That means it is associated with a good prognosis. So luckily, majority cases of asthma are extrinsic asthma, right? So in majority of them, the prognosis is good. The prognosis is good. So that is why we say, when a child, young boy, presents with episodes of wheezing, bronchospasm, it may be happening twice a week. But the moment they take bronchodilator, the attack subsides immediately. Each attack is mild in intensity and responds well to the standard therapy. They also have other telltale signs of allergy, making the diagnosis easy, and the prognosis is good. Prognosis is good. But when to suspect intrinsic asthma? Intrinsic asthma can occur relative to that. More commonly, the onset is adult onset. More commonly, they are in adult onset asthma. Please remember, adult onset asthma are also commonly atopy only. But compared to both of them, child and adult, the risk of intrinsic asthma is more in adult. More in adult. They can be associated with aspirin sensitivity. They can be associated with aspirin sensitivity and nasal polyp. Aspirin sensitivity and nasal polyp, they can be associated with. Here it is difficult to diagnose because the attacks are rare. The attacks are rare, maybe twice or thrice in a year. Attacks are rare, twice or thrice in a year. So patient may forget also कि बीमारी है, but each attack is life threatening. So it does not come, but when it comes, it may take the patient only away. Each attack is life threatening, and relatively it has got a poorer response to treatment. It has poorer response to treatment, making the prognosis unfavorable. Making the prognosis unfavorable. Please remember, death in asthma is never common. death in asthma is never common. So it is not that they are going to be fatal or poor, unfavorable. Compared to the extrinsic asthma, they can have a relatively stormy course. That is why we want to identify the type of asthma. So now I want you to say clinical feature apart. Clinical feature only tell you probability. What is the best test to differentiate between the two? What is the best test to differentiate between the two types of asthma? Tell me, what is the best test to differentiate between the two types of asthma? So if a patient has got young boy, now listen to this clinical picture. If the MCQ says it is a young boy also having allergic rhinitis or itching rash over the skin, getting attack 1 to 2 per week but mild in intensity, promptly responding to treatment, you know probably that it is extrinsic. And if it is not, you know it is intrinsic. But just you knowing is not enough. You need some stamp, you need evidence. So what is the best test that you need for the diagnosis? Correct. Atopy. Answer is to go for serum IgE levels. To go for serum IgE levels. Because in a extrinsic asthma, the serum IgE levels will be elevated. Allergy, atopy is the problem. But in the intrinsic asthma, it may be normal or even low. It may be normal or even low. So it is the best single test to differentiate between the two types of asthma. So what we must know is that we all know the clinical feature of asthma. That young boy presents with cough, wheezing. You suspect asthma. Most of them are classical, which you can document using serum IgE level. With the increasing environmental pollution, adult onset asthma is also increasing, where the mechanism may not be understood and they may have poorer response to treatment, and they may actually have normal or low IgE levels. Normal or low IgE levels may be present, right? So look at the clinical feature together. So already I have written. So epidemiology we wrote, etiology we wrote. So what is the clinical feature of asthma? What is the clinical feature of asthma? They present as episodic cough. They present as episodic cough, which is most common feature. Episodic cough with or without breathlessness. Please remember, breathlessness is not necessary to happen in every patient. Breathlessness is a symptom of severity. It will occur if the disease is severe. Okay. So most common symptom of asthma, they present with episodic cough with or without breathlessness. On examination, you can here auscultate the characteristic expiratory wheeze. You can auscultate the characteristic expiratory wheeze is present. So asthma is a relatively common disease. So how should we diagnose the asthma? For diagnosis of the asthma, first we must have clinical suspicion. First we must have clinical suspicion for diagnosis. After clinical suspicion, you must proceed for spirometry, because radiology is non-specific. Radiological features are non-specific for asthma. You proceed for spirometry. What does the spirometry show? Please refer to the approach video. What does spirometry show? The FEV1 to FVC ratio less than 0.7. So it shows obstructive pattern. So what does the spirometry show? Obstructive pattern with excellent bronchoreversibility, improvement in the FEV1 by more than 12% post salbutamol. Post salbutamol, excellent bronchoreversibility is the gold standard of diagnosis. It is the gold standard of diagnosis in a patient with bronchial asthma. So the diagnosis does not need radiology. Radiology is to exclude other differentials. The asthma can be confirmed on spirometry. But please remember, after the diagnosis, every patient must undergo serum IgE levels to identify the type, and the prognosis of asthma. Already we have written in the table. Must undergo serum IgE level to identify whether it is extrinsic or intrinsic. Accordingly, you can predict the outcome of the disease. You can predict the outcome of the disease. But the moment you tell, in modern day practice, if you tell the patient that you have got asthma, their question will be, doctor, how bad is the asthma? How bad is the inflammation? What is the risk that I will get an acute attack? They will ask you questions about the severity. And till now, we don't know. Spirometer only told me diagnosis. Ig level told me type and prognosis. So to identify the severity, we have got exhaled nitric oxide levels. Exhaled nitric oxide level is a approved test, approved for identifying the severity of the disease. Exhaled nitric oxide level is approved for the severity of the airway inflammation. To identify the severity of the airway inflammation and also the risk of impending attack. Also the risk of impending attack. Okay, so what it is? It is a non-invasive breath test, easy to perform. It is a non-invasive breath test. It is a non-invasive breath test, and the exhaled nitric oxide level, exhaled nitric oxide levels correlates directly proportional to the severity of the disease. It is directly proportional to the severity of the disease. Directly proportional to the severity of the disease. So understand and write. So asthma is a very common problem all over the world. It's a very common problem. Okay, with increasing environmental pollution, the incidence of asthma is increasing in the world. So most common victims are children, especially the young boys who suffer from the disease. But luckily 80% are going to be extrinsic, that is related to atopy, which respond to treatment well, but they need to be identified. And to identify the prognosis, severity of the disease, you can also take the help of exhaled nitric oxide level. Take the help of exhaled nitric oxide levels. So once diagnosis is confirmed, so diagnosis कैसे करते हैं? Based on the clinical feature, examination finding and spirometry confirms the diagnosis. IG tells you type and exhaled nitric oxide tells you severity of the disease. Once the diagnosis is confirmed, we proceed to the treatment. We proceed to the treatment of asthma. Proceed to the treatment of asthma. Please remember, the treatment of asthma is now divided into the two. The treatment of asthma, we are going to follow the GINA guidelines. We are going to follow the GINA guidelines. What is GINA? The Global Initiative Against Asthma. Global Initiative Against Asthma we are going to use. So for the treatment of asthma, we have adopted the GINA guidelines. So depending on the presentation, asthma can come as an acute attack also. They can come for chronic prophylaxis also. So treatment also divided into two. How will you manage acute attack of asthma? Question number 1. How will you manage an acute attack of asthma? Question number 1. And then we will discuss the chronic prophylaxis of asthma. Okay. So the treatment part of asthma divided into two. So it depends on the clinical presentation of the disease. Depends on the clinical presentation of the disease. Clinical presentation of disease. It can come with acute problem. Acute problem ends up in the emergency. Comes to the emergency. So in the acute attack, you are going to classify the acute attack of asthma into two. You are going to classify acute attack of asthma into two, whether they are mild to moderate acute attack, or is it severe, life threatening? Is it severe, life threatening? You want to know severe and life threatening. We want to know. Acute attack of the disease, acute attack of asthma, we want to know. So how do we differentiate? It is a clinical differentiation, means no test is required. Patient comes with acute attack using 10 clinical parameters. We will write them. You want to classify whether it is mild or severe. So whatever we do in the casualty, now we have to do it in the MCQ also, based on the 10 parameters. What are the parameters? When the patient walks into the casualty, you can see whether the patient is got orthopnea. Orthopnea means breathless at rest. Orthopnea means breathless at rest. Number 2, we want to see whether the patient is able to recline on the bed for examination. Okay, follow this very clinical point. When the patient comes into the casualty, the sister, the nurse will tell the patient to lie down for examination. Whether the patient is able to recline or not, we want to see. We want to see the ability to speak. we want to see the ability to speak sentences. You want to check the ability of the patient to speak complete sentences. See, most commonly, what's the first question you are going to ask? क्या नाम है आपका? So before you ask क्या तकलीफ है, please ask them क्या नाम है आपका? So that is a good way of initiating history taking rather than directly bombarding क्या हो रहा है, क्या हो रहा है, क्या हो रहा है ना, क्या हो रहा है बताएगा वो, but focus on first introducing, making him comfortable also. So orthopnea, able to recline, ability to speak sentences, we will consider. Then you will do general examination. On the general examination, you want to look at the pulse rate. On the general examination, you want to look at the pulse rate. Instead of blood pressure, I will use the word pulsus paradoxus. I will look for presence of pulsus paradoxus. I will look for respiratory rate and the presence of central cyanosis. The presence of central cyanosis needs to be looked at. So first three symptoms are clinical, history, observation. Next four symptoms are related to general examination. General examination. Proceed further to systemic examination. Systemic examination. What is the auscultation finding? What are the auscultation finding? What is the state of the accessory muscles? What is the state of the accessory muscle? You want to see how much is the effort for breathing, and you want to look for neurostatus. You want to look for neurostatus based on these 10 clinical parameters. Based on the 10 clinical parameters, you want to start the treatment protocol. Based on the 10 clinical parameters, you want to start the treatment protocol. So you have to read it in the MCQ also. It is an emergency. Read it in the MCQ also. What you will read in the MCQ here? Read in the MCQ like this. Okay. So till here, what will be the typical story? A young boy or a young girl, known case of asthma on bronchodilator therapy, walks into the emergency room with complaints of breathlessness. The patient who is a known case of asthma walks into the emergency room with complaints of breathlessness. So what do you know? The patient has got a acute attack of asthma. You know that. Patient has acute attack of asthma. Once they come, read on further. What is the finding? The patient is walking into the casualty and not breathless at rest. The patient is able to recline on the couch for a detailed evaluation. The patient is able to say the name and the complete address without any problem. The examination, the pulse rate is less than 110 per minute. The pulse rate is less than 110 per minute. Pulsus paradoxus is absent. Pulsus paradoxus is absent. The respiratory rate is less than 30 per minute. No tachypnea. There is no central cyanosis. There is no central cyanosis. Auscultation shows characteristic expiratory wheeze is present. Characteristic expiratory vis is present. The accessory muscles are healthy and normal. The neurostatus is intact, means the patient is conscious, oriented to time, space and person. The patient is conscious, oriented to time, space and person. All is well. All is well. So this is what we call it as an acute, mild to moderate attack of asthma. But if it is a severe attack of asthma, what will you do? Severe attack of asthma, when the patient is brought gasping to the casualty. Patient is unable to recline, restless, patient is restless, unable to recline for examination. Patient is able to speak barely audible words. Barely audible words, patient is able to speak. The pulse is more than 110 per minute. Pulsus paradoxus is present. Respiratory rate is more than 30 per minute. Central cyanosis is present. Auscultation shows silent chest. Silent chest we learn, no? Ominous sign. It is a sign of severe airway obstruction. It is a sign of severe airway obstruction. The state of the accessory muscles are in a state of impending fatigue. The patient is looking tired. The muscles are prominent and fatigue. And the patient is either stuporous or comatose. So neurostatus is altered. So if a patient with acute attack has got any one of these findings, all need not be there, all will not be there, rather any one of these findings, you are going to classify them as a patient with severe life-threatening asthma. You are going to call them as severe life-threatening asthma. We are going to classify the patient as. But क्या होता है ना, in practice they all occur usually in concordant, no? When the patient is severely breathless, then only they are tachypneic, then only there is tachycardia, then only there is cyanosis and so on. It is not an MCQ that one will be there, other will not be there. So you, in the given question, you have to identify whether it is a mild moderate attack or it is a severe acute attack of asthma. Let's go to the treatment now. So what treatment would you like to give? If the patient has got acute attack of asthma, mild to moderate attack of asthma, mild to moderate attack of asthma, what you want to do? In mild to moderate attack of asthma, you want to give the salbutamol, short acting beta agonist. Short acting beta agonist is indicated. Salbutamol is the drug of choice. So in pharmacology we learn salbutamol is the drug of choice. Salbutamol is the drug of choice. Short acting beta blocker. In what way? Nebulization is the best route. Nebulization is the best route, because in the nebulization the aerosol size becomes less than 5 millimeter and helps reach the deep area of the lung, helps in better penetration of the drug. So it can reach deep into the lung. It can reach deep into the lung. So if a patient has come to the emergency room, I am going to give the patient salbutamol nebulization. I am going to give the patient salbutamol nebulization because it aborts 85% success in aborting the attack. 85% success in aborting the attack. Then I will go on to the prophylactic guidelines. Okay, then I will connect it to the prophylactic guideline. So once I give nebulization with salbutamol, 85% attacks will improve. But in refractory cases, if the attack is persistent, if it is refractory to salbutamol nebulization, then what I can do? I can go for ipratropium nebulization, anticholinergic. Ipratropium nebulization can be given. Ipratropium nebulization can be given in this patient. If SABA did not relieve, I can also give ipratropium nebulization can be given to this patient. If they still don't improve, if after the ipratropium also, if the patient does not improve, what can I do? If they do not improve even after ipratropium nebulization, I want to give IV corticosteroids. I want to give IV corticosteroids need to be given. IV corticosteroids need to be given. So you are escalating the treatment little by little. So if it is still persistent, you give a shot of IV corticosteroid. And if it still does not improve, problem remains persistent after giving steroids also, you must consider inhalational anesthesia. You must consider inhalational anesthesia and ventilator support. You must consider inhalational anesthesia and ventilator support. Among the inhalational anesthesia, the most preferred is sevoflurane because it has got maximum bronchodilator action during the acute attack. So during the acute attack, if the patient is not responsive, still breathless, after giving the steroid also, I can induce the patient using inhalational anesthesia, sevoflurane, and proceed for mechanical ventilator support. Proceed for mechanical ventilatory support should be preferred. Mechanical ventilatory support can be offered to the patient. Mechanical ventilatory support is offered to the patient. But if the patient has a severe attack, stuporous comatose, then what you do? Reverse the trend. You start with mechanical support. If they are serious, first step is to save the patient. Patient is cyanosed, comatose. Now nebulization nahi. First you give mechanical ventilatory support and then you proceed to the other algorithm. First line becomes ABC, no? Airway protection type. Patient has come with severe breathlessness. Then the first line becomes mechanical ventilatory support followed by pharmacological therapy. So mild case start with nebulization. Severe case start with ventilation. That's our point. So what is no longer recommended in the guideline? What is no longer there? Methyl xanthines are gone. Our country loves deriphyllin. They are gone due to risk of cardiotoxicity. Due to risk of cardiotoxicity, arrhythmias they can cause. Due to risk of cardiotoxicity, methylxanthines are no longer recommended in the acute management of asthma. But please remember, majority patients recover. Majority cases recover. There is very low mortality. Very low mortality in an acute attack of asthma. There is a low mortality in acute attack of asthma, right? So if you meet senior professors in your hospital, they will actually go on to say that low bhi nahi, there should be no mortality in asthma. If an acute attack of asthma dies, problem is not with asthma, problem is with you. Okay, so people believe that asthma may be common, but it is rarely life-threatening. Rarely life-threatening. Most patients of acute asthma will recover uneventfully. Mortality is low. Mortality is low. So very important MCQ approach. Acute attack of asthma. Common question. So we are going to follow the GINA guidelines for the management of asthma. When they come with acute attack, you have to do a clinical grading of severity and proceed with the treatment. Luckily, as I told you, mortality is low, patient's outcome is good. After the acute attack is gone or patient was diagnosed only during a comfortable time, you can proceed with chronic long-term treatment. So what is the long-term treatment? What is the long-term management of asthma? What is the long-term management of asthma? This is the place where we have got a few updates that are happening. What is the long-term management of asthma? How should we proceed? Long-term management of asthma. How should we proceed? Previously, what we used to do, we used to prescribe the patient. And listen to this, it's important to know the past, then only you can understand the future better. So initially we used to say, after the patient was diagnosed with asthma, we used to give the patient a salbutamol inhaler. You will see many patients in India still carry Asthalin inhaler in their bag. And you tell them to take SOS. Zarurat padega to lena. So you used to tell them to use only the short acting bronchodilator. So let's understand what was the old thing. So old concept was to give the SOS use of short acting bronchodilator, that is beta agonist inhaler as a rescue therapy, as a rescue or a relief therapy. So what we were doing previously, when the patient was diagnosed with asthma, we used to tell them to take SOS salbutamol. We used to tell them to take SOS salbutamol as the rescue or the relief therapy. Unless it became repetitive, then we would start them on long-term prophylaxis. Otherwise, we used to tell them only take it as required. But what are the problems? What are the disadvantages of this method? Okay, MCQ. What happens if you take only SABA as the rescue or relief therapy? First of all, there is going to be like a tachyphylaxis. What is happening? Immediately there is a beta receptor down regulation. There is a beta receptor down regulation within weeks of the use. So if they end up taking, let us say, thrice a week, 4 times a week, they take it as required, it will immediately cause beta receptor down regulation. It will occur immediately. It will cause beta regulation. That is why it will cause lesser relief, lesser response in acute attack. This will cause lesser response in acute attack, lesser response in acute attack, and make them prone to life-threatening episodes. Make them prone to life-threatening episodes of the disease. And that is why, according to the new update in the GINA guidelines, isolated use of SABA is not recommended. According to the new update, what we have to use? We have to give low dose inhaled corticosteroid with formoterol. LABA, formoterol, that is LABA, long acting beta agonist. Long acting beta agonist is recommended for the as the rescue or the relief therapy also. Recommended as the relief therapy also. So long-term management number 1. Isolated use of SABA, ethylene for relief is no longer recommended. You have to always use it with inhaled corticosteroid. You have to always use it with inhaled corticosteroid. You have to use it together only. Use it with inhaled corticosteroid. So if they ask you overall what is drug of choice for asthma, it has become inhaled corticosteroid. Because what is the pathology? Bronchial airway inflammation. How to reduce the inflammation? By giving steroids, by giving inhaled corticosteroid. Okay, so salbutamol, except in emergency, we don't give. Now as a rescue at home also, it is no longer preferred. You are supposed to use it always with low dose inhaled corticosteroid and formoterol. So even when a patient comes in acute attack, after nebulizing, I am going to start the patient on low dose ICS and formoterol inhaler. Low dose ICS and formoterol inhaler should be started as the relief therapy. Next, what is the update? The new update we have adopted. What have we adopted? We have adopted a stepping up, step up or step down therapy. It is called a step up or step down approach. So adopted a step up or step down approach, okay, in the management of the asthma. So what you are going to do? Initially what we are going to do? We are going to assess the patient. We are going to assess the patient. Once we assess the patient, we are going to treat the patient. Once we assess the patient, we are going to treat the patient and adjust the dose. Treat the patient and adjust the dose. And then we continuously review. Continuously we have to review. So this cycle, assess, treat and adjust and review, is a continuous process. So once the diagnosis is confirmed, the patient is given a inhaler of combination ICS plus formoterol to take as a relief therapy. So we are going to adopt this step up or step down approach. So when do we do review? Every 6 to 8 weeks. You have to review every 6 to 8 weeks. If the disease is controlled, you continue the same thing. If the disease is not controlled, you step up the therapy. So the step 1 of the therapy, okay, the first line treatment is to just give the use of SOS use of as required use of the low dose inhaled corticosteroid plus formoterol. The step number 1 is to give the patient as needed use of low dose corticosteroid and formoterol. So what you are going to review? If the patient is getting attacks, 2 or more attack per week, or more than 1 nocturnal attack per week. So after telling the patient to take the SOS ICS plus formoterol, you will review after 6 to 8 weeks. You will ask if the patient is getting 2 or more times they have to use the inhaler, or more than once in the night every week they have to use the inhaler. If it is yes, then you go on to the next step. So it is a stepwise therapy. So till the disease is controlled, you step up the therapy. Once the disease is controlled, you step down the therapy. Step up or step down therapy we want to use here. So what step next we have to adopt? If it is not working alone, so then what you do? You do regular use. So daily use of the low dose corticosteroid, plus formoterol inhaler. You switch to daily use. If it is not controlled even with this, what you do? You switch to moderate dose. Inhaled corticosteroid plus formoterol inhalation. So as the disease remains uncontrolled, you are reviewing every 6 to 8 weeks. If it is not improving, you go on to the next step little by little. And if it is still not controlled even after this, then you have got a plethora of agents. You can add LAMA. What is this LAMA? Long-acting anti-muscarinic agent. You can add long-acting anti-muscarinic agent, tiotropium bromide can be added to the regimen. What does the new update says? It improves the lung function. lung function, your working capacity. That's how it relieves the symptom. It improves the lung function but may not relieve the symptom, much. But if you test, it has shown improvement in lung function. That is why it is recommended as the next step. If it still does not work, you will have to consider the biologicals. Which are the biologicals? Monoclonal antibody derived from the live cell culture. That's why the name biological. Derived from the live cell culture. That is why the name biological. We are going to call this as biologicals. Which are the biologicals approved for therapy in asthma? Which are the biologicals approved for the therapy in asthma? Let us write it down. Which are the biologicals? We have got biologicals are anti-IgE antibody. We have got anti-IgE antibody. I am sure all of you know omalizumab. The first biological that came for asthma was omalizumab. Now then we had interleukin 5 antagonist. Interleukin 5 antagonist are also approved. Mepolizumab and the reslizumab are approved for the treatment of asthma. And now we have got also the IL-4 antagonist, that is dupilumab. IL-4 antagonist, that is dupilumab, is also approved for the management of asthma. Approved for the management of asthma. Additional to this, you can also use leukotriene antagonist. Leukotriene receptor antagonist montelukast for additional relief of symptom. You can also use leukotriene receptor antagonist for additional use of symptom. So montelukast has been to and fro drug, because there were initially clinical trials which said that montelukast is sometime as effective as oral steroid. They said it is almost as effective as oral steroids. It is as effective. But then the evidence remains to and fro. So what is must to be done is what we have written. So how to treat? So first level treatment, according to the new update, what is the first thing that has done? Irrespective, once the diagnosis of asthma is confirmed, prescribing only a salbutamol inhaler is criminal. Okay, that is no longer recommended. So what should we do? We must start the patient on the low dose inhaled corticosteroid and formoterol as the relief therapy. So that is what you will continue as long as the need for the inhaler is low. But if the patient has to use this for more than 2 times a week or more than 1 nocturnal attack a week, then you go to the next step. Then you tell the patient to take the medicine every day. But if that also does not work, you increase the dose of steroid and add formoterol inhalation. That you continue. If still does not work, you add LAMA, long acting anti-muscarinic agent, tiotropium bromide. And if it still doesn't improve, Of course, we are using oral steroids in between, but that is not ideal, because there is oral steroids also in between that you can give, but steroids should be given for short course only, and for long term prevention you must consider the biologicals. Steroids come with their own set of side effects. Consider the biologicals. So we have got anti-IgE omalizumab, IL-5 mepolizumab, reslizumab, IL-4 antagonist dupilumab. You can also use leukotriene receptor antagonist like montelukast. We can use this for the prevention. So what we have got? Thanks to the new guidelines, we have got plenty of options. That is why the overall prognosis of asthma is now excellent. Overall prognosis of asthma is excellent, nothing to worry. So is asthma a common problem? Yes, it is a common problem, no doubt about it. It is a common problem, but it can be easily controlled with the step-wise approach. And we have got many new agents approved for the management of asthma. In acute attack also, mortality does not occur. So if they are controlled well, they can have normal or good quality of life. They can have good quality of life. Right? Let's come to the next step. What did I say? At the start of the lecture, I told you that even though we are discussing this management of asthma here, what we are going to focus on? This update. We are going to focus on this update, GINA 21 update, which we have written as a part of treatment. And we are going to add a short note of correlation or interrelation between the COVID-19 and asthma, which the GINA 21 update has published. So we want to know what is the relation, what is the interaction between asthma and COVID-19. Asthma and COVID-19 infection, what is the interaction? So this we must know. This is a current topic. Asthma and COVID-19 infection, interaction, we must know. So the first point is, people were worried, asthma, comorbidity, death is more? No. So there has been no increased mortality. There has been no increased mortality due to COVID-19 in asthma. That is point number 1. So there has been no increase. There has been no increased mortality due to COVID-19 pneumonia in patients of asthma, though there was an increased risk of COVID-19 infection. There was an increased risk of COVID-19 infection in patients, in cases who received oral corticosteroids recently. So risk of infection was there, but luckily there was no increase in the mortality. No increase in the mortality due to COVID-19 infection in the asthma. That much we know. But the important thing was, when we admitted the patients, what is to be avoided in therapy now? So in the treatment, we have to avoid nebulizer or the spirometry to reduce the spread of the virus. So Gina said, even if you get asthmatic attack, use inhaler. Do avoid use of nebulizer or spirometry to reduce the spread of the infection. Avoid the spread of infection. And in asthmatic patient, to continue the annual influenza vaccine. That is the hot topic now, no? So when the wave is going away, we are all focused on vaccination. So asthma patient who receive annual influenza should continue to receive annual influenza vaccine. So there should be a gap of 14 days between the influenza and the COVID vaccine. Influenza and the COVID vaccine. There should be a gap of at least 14 days between the influenza and the COVID vaccine. And the biologicals for asthma. Biologicals for the asthma and the vaccine must not be taken on the same day. Must not be taken on the same day. Taken on the same day. They must not be taken, especially to monitor the adverse drug reaction. To monitor the adverse drug reaction. We won't know what is the problem. We won't know what is the problem. So please remember, asthma is a common problem, and now anticipating the child wave, third wave, asthma is common in children. But rest assured, there is no increased mortality that we have found. Though if the child of asthma has received oral steroid, then the risk of COVID-19 infection is higher. In the management, we avoid nebulizer or spirometry. Annual vaccination with influenza to continue with a gap of 14 days between influenza and COVID. And if the patient of asthma is on biological, they should not take the injection of biological and the vaccine together, because it becomes a hindrance between monitoring adverse drug reaction. Right? So with this update of interaction between asthma and COVID, right? Should we stop the session? No, नहीं, अभी तक नहीं. तो क्या रह गया? तो asthma हमने पढ़ा. But still there are MCQs which are targeting the different variants of asthma. So what we have studied is the classical asthma and the management we have studied. But still there are few variants of asthma that we want to know. We still want to understand few variants of their asthma. Variants of asthma and their clinical significance. We want to understand variants of the asthma and the clinical significance. One of the most famous variant is the nocturnal variant of asthma. We have got the nocturnal variant of asthma, where the patient gets symptom only at night. Where the patient gets symptom only at night, the patient gets the symptom. Becomes very difficult to diagnose. So the diagnosis requires you to perform, if there is a more than 25% decrease in the FEV1 values during the night time as compared to the daytime, it confirms the nocturnal attack. So clinical variants are there. We just give names. They are all asthma, but some mild differences. Typical asthma can come anytime, no relation to exertion. But some people get frequent night attacks, which is very difficult because disturbs the sleep and irritates the patient. So how to confirm? You will have to do spirometry at night because daytime value may be normal. So in patients with nocturnal symptom, you must do nighttime spirometry. But the drug of choice remains inhaled corticosteroids. Inhaled corticosteroids remain the drug of choice. It will prevent the nocturnal attack also. So night they take ICS and the patient will feel fine, no problem. Drug of choice is the inhaled corticosteroid. The next variant is the exercise induced asthma. Okay, the next variant we have got is the exercise induced asthma. Exercise induced asthma. Now this exercise induced asthma, why does it occur, when does it occur, and how to control are the questions that are asked. Okay, when does it occur? When does it occur? Typically occurs within 30 minutes post exercise. Typically occurs within the 30 minutes post exercise. Okay, it does not occur before or the peak. No, it occurs after the exercise. Why? Post exercise there is hyperventilation. Post exercise there is a hyperventilation that occurs. Hyperventilation that occurs post the exercise. Imagine if you have ran up a flight of stairs, है ना, even if you have ran 4 माला चढ़ के भाग के आए हो, चढ़ते समय कोई प्रॉब्लम नहीं होता. Once you reach the top, you start panting, no? You start panting. Post exercise, hyperventilation causes dryness. It causes dryness of the respiratory secretions. It causes drying of the respiratory secretions. So dryness occurs. We feel, no, dry mouth, dry throat, सब कुछ गला सूख जाता है. So there is dryness, increased osmolarity of the respiratory secretions. This causes activation, mast cell activation. Mast cell activation, which provokes a bronchospasm in a susceptible person. Bronchospasm in a susceptible person, that is exercise induced asthma. So why I am using the word, does it occur in everyone? No, does not occur in everyone. Many times after having heavy exercise, we may also feel a little bit of tightness in the chest, no? फट जाती है कभी कभी. You feel कि heart attack तो नहीं हो गया मुझे, है ना? It's not a heart attack, it's a physiological transient bronchospasm that can occur. But in a susceptible person, they can develop asthma, like exercise induced asthma it is called. So how to prevent? The drug of choice, if the question is asked, drug of choice remains inhaled corticosteroid. You can also use, obviously, mast cell stabilizer can also be useful in the therapy. Mechanism hai na? You can use the inhaled corticosteroid before the exercise. Corticosteroid before the exercise. In addition, you can also give mast cell stabilizer to reduce the risk of attacks. But also you want to perform graded training. Okay, so in the management, long-term management, you want to also tell the person to have graded exercise. Graded exercise, that is conditioning. So you are doing conditioning. You are doing conditioning for this patient. Conditioning. So you tell them to train more in a graded manner. Suddenly नहीं बढ़ाने का. In a graded manner, it will help reduce the risk of developing this post-exercise bronchospasm. Help reduce the incidence of post-exercise bronchospasm. And finally, there is a condition which is called as brittle or labile asthma. As the name says, brittle means fluctuating, labile asthma. So there is a rapid fluctuating asthma. Some people can have brittle asthma, labile asthma. So brittle asthma has further two types. There is the type 1 brittle asthma. There is the type 1 brittle asthma. In the type 1 brittle asthma, what we are going to see? In the type 1 brittle asthma, the patient is dependent on the steroid. The patient is dependent on the steroid. So the patient is controlled on steroid, but any attempt to taper can precipitate acute attack, can precipitate an acute attack. So you have started the patient on steroid and you feel ki was, patient is doing well, patient is doing fine, patient is responsive to steroid. So he is dependent in a way, but the good part is what? He is steroid responsive. But the problem is the moment you taper the steroid, they develop an acute attack. So as good as it is like a steroid dependent case, as long as you give steroid, all is well. The moment you taper, they develop an acute attack. But it is the type 2 which is MCQ favorite. The type 2 brittle asthma. The type 2 brittle asthma, MCQ favorite. What is that? It is the only type which is refractory to steroid. It is refractory to steroids. Okay? They present with sudden severe exacerbation. They present with sudden severe bronchospasm. They present with sudden severe bronchospasm which mimics anaphylaxis. And that is why the drug of choice here is to go for adrenaline. You want to give epinephrine. Epinephrine pen you have to use. Epinephrine pen you have to use, like for anaphylaxis. So there are different variants of asthma. So asthma is basically a condition where the airways are hyper responsive to surrounding stimulus and can develop episodic bronchospasm. The classical asthma is related to allergy and responds well to treatment. All is well. The intrinsic asthma can be little unfavorable because response to the standard therapy, because first line you are going to give inhaled steroid, but problem is not allergic. So the initial response may be not very promising. But nonetheless, acute mortality is low with the availability of newer agents, biologicals, the prognosis of asthma is become excellent, right? But there are few variants which are specific, cumbersome also. So nocturnal attack, where patient has night attack, daytime spirometry normal, तो diagnosis miss हो जाता है. Daytime spirometry normal misses the diagnosis. The diagnosis can be missed. That is the problem. Exercise induced asthma is another thing that we must know about. Exercise induced asthma we must know about. And the brittle asthma, out of which type 1 is problematic because it requires constant steroid. But the type 2 is dangerous because it can suddenly patient can collapse like an anaphylaxis. So you will have to train the patient to use the EpiPen. Self-administration must be known to the patient, right? So this completes our topic of asthma with a special reference to the new guideline and COVID-19 also. New guideline and COVID-19 also, right? So next video we will be discussing the other airway disorder, bronchiectasis and the associated syndromes, right? See you there.